Hello, everyone, and welcome to Low Burden Tobacco Cessation Strategies and Strategic Community Partnerships. This is our final webinar sponsored by the Washington Department of Health in this community of practice. We do have a lot of material to cover today, so I'm going to go ahead and just get started right away. And of course, as always, before I completely get started, I do want to go through a little bit of housekeeping. Everyone is currently muted. If at any time you have technical difficulties, please use the chat function to contact Amy Hansen. She's on the line to help us out. The chat function is available at the bottom of your screen. Hit the icon that looks like a word bubble with 3 dots around it. During the Q&A session at the end of the presentation, there are 3 ways to ask questions. You can mention, or you can use the chat button that I've already mentioned. You can use the Q&A icon. At that point, a box will pop up and you can just ask, you can type your question in there. And you can raise your hand. If you raise your hand, we will unmute your line and you can use your computer audio to just tell us what your question is. Okay, so with that all out of the way, thanks again for joining us today for this webinar on the theme of creating sustainable solutions to address nicotine dependence across engagement settings. My name is Jim Pavlik, and I'm the Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. In my capacity here at BHWP, most of my work is in assisting organizations to adapt their workflows for a variety of clinical quality improvement initiatives, mostly focusing on chronic disease prevention and control, with a particular emphasis in tobacco cessation interventions. Today's learning objectives are relatively simple. We want to highlight several actions that you can take to move your organization in the direction of providing a comprehensive suite of effective, efficient cessation interventions, ideally with the resources that you currently have. And to do that, I'll have to define what we mean by low burden. I'll have to list and describe at least some of those actions that you can take, and I'll provide some resources to guide you as you adapt the best practices defined here and in the other webinars that we've done, so that you can match your goals and what you're able to do to achieve those goals. So before getting too far along, I do want to take a little bit, just a sort of a tangent a little bit to talk about the term sustainable. Typically in a presentation like this on low burden strategies, we would talk about scalability and sustainability. And one point I'd like to make is that as a general rule, all scalable initiatives are also sustainable, but not necessarily the other way around. So of the two, being sustainable is the more important. And I'm essentially using the terms low burden and sustainable as rough synonyms. The former emphasizes the impact on your staff today, and the latter emphasizes the feasibility of maintaining these improvements over longer time horizons. In my experience, changes perceived as low burden today are much more likely to still be around in a few months, a couple of years, or into the long term. That is to say that if they are experienced as low burden activities now, they're more likely to be in fact sustainable. So by low burden, we mean primarily 2 things, the 2 things on this slide. And one of those things is economic, and one of those things is psychological. The first thing is that the benefits that are delivered, the cessation services that you're performing, are worth the costs that are incurred to deliver them, which is to say that nothing's free. Everything's going to take time. Everything's going to require training, those sorts of things. So is it worth it? And those benefits, whatever they are understood and appreciated by those who perform the services. So on number 1, in a narrow sense, we could be talking about our ROI, or our return on investment. If we determine that a project costs an additional $100 per client, but saves the organization $200 per client, then we'd say that the project is worth doing. But we may consider it's worth doing even if the ROI were narrower than that, provided that the project serves some other purpose important to the organization, like fulfilling our mission to care for our community, for example. On number 2, we're primarily talking about the culture of the organization itself. Many tasks have been forced on employees over the last 20 years or so. Caregivers spend anywhere between 40 and 70% of their day doing administrative work instead of providing care. No action, program, or suite of services can be considered sustainable if the staff are actively pushing back against the execution of that program. Which is all to say that we define low burden initiatives as those that satisfy at least the first criteria, and which are housed within a robust policy regime that aids in the satisfaction of the second. To satisfy criteria 1, of sustainability. An intervention must work. It must convey some benefits to the staff directly, but more importantly in this realm, to the client. A tobacco cessation intervention must successfully get people to quit tobacco. So which interventions work? And to know that, we have to understand some things about quit attempts in general and where we can have an influence on them. And in order to do that, I want to do some back of the envelope calculations. And at first, I want to say what I mean by that. The numbers that will appear on this slide are approximations. They take a lot of things for granted. They have not been vetted by an epidemiologist. To emphasize the lack of precision here, I've done a lot of rounding down to show more conservative figures. I also chose the lower and upper ends of certain estimate ranges selectively to favor conservatism. This is because my goal here is not to exaggerate what's possible, but I'm also not doing this to offer actual projections that might be truly achievable either. I'm doing this merely as an exercise to build intuition around the scale of our potential impact and for whom our efforts will be most impactful. So we begin with about 850,000 smokers in Washington, and about 75% of tobacco users report they want to quit within the next year. Now, these figures are for adults only, so it's worth mentioning that most individuals younger than 18, when they're asked if they imagine themselves as a smoker at 30, say no, they don't. In fact, by the time tobacco-using teenagers reach the age of 18, 50% of them have reported having tried to quit already and failed to do so. So going back to our adults, when we asked them if they went one day in the past 12 months without smoking with the intention of becoming abstinent, only about 65% report that they did. The group represented by that gap, the gap between those who want to quit, who say they want to quit in the next 12 months, and those who actually try each year, I refer to as Group A group of about 85,000 folks with a 0% abstinence rate at the end of 1 year because they didn't try. A group that, if we could reach them all and persuade them all to use counseling plus medication, could result in about 21,000 additional quits. Now I want to take a pause for a moment after just these statistics. Many presentations begin with an argument, an appeal to, why are we talking about this? Why does it matter? I didn't start with one because you're part of this community of practice, so I assume everyone is on board with the general idea that helping our clients to quit is a good one. Nevertheless, there are some common misconceptions that I feel compelled to address at this moment because this is where they become relevant. Because I'm tossing around numbers like how many people want to quit and what are their success rates if they try. So it's worth figuring out if the behavioral health population may be significantly different than the general population reflected on these 3 bullet points. One of the major misconceptions is that individuals with behavioral health conditions smoke at higher rates out of a greater need. This greater need leads to a lower desire to quit, and the lower desire to quit impacts success rates negatively, resulting in higher prevalence rates. And we do know that the behavioral health population has higher prevalence rates, about 2 to 3 times higher than the general population, so this pathway seems plausible. So it's worth stepping back to consider, do individuals in the behavioral health community want to quit at lower rates than the general population? And what impact do their conditions have on their ability to quit? It is indeed the case that the individuals in the behavioral health population share certain inputs and outcomes, and among them are poverty as children and lower educational attainment as adults. These factors combine to create lower incomes, higher chronic stress, more involvement with the criminal justice system, and other things. But it is also the case that the tobacco industry is aware of these associations and have deliberately marketed their products to those groups, thus driving up prevalence rates beyond any hypothesized, say, natural or base rate that may occur in any such population. It is also the case that tobacco use causes, contributes to, and aggravates various conditions. It primes the brain for future addictions. It can increase pain sensitivity and increase the power of certain opioid effects. It can dampen the power of various therapeutic drugs, including certain painkillers like acetaminophen. And in addition to the causal and associational links between smoking and behavioral health, co-treatment of nicotine and other substances can positively affect the chances of remaining abstinent from both drugs. While individuals with behavioral health condition only make up about 25% of the total population at any given time, they account for about 34% of all cigarettes sold, which is to say that not only is the prevalence rate in this population higher than the general population, they also smoke more cigarettes. This means more instances of chronic disease, more money being spent, more time out of the day being taken up by their addiction. In short, while the prevalence rate is higher, the need and desire to quit are also higher. So to correct our misconception, what we really see is that those suffering from a mental health or substance abuse issue are more likely to lack access to therapeutic services and thus rely on smoking as self-medication or a coping strategy, which drives up use. This vulnerability attracts the interest of the tobacco industry, which increases its outreach to this population, which further drives up use, both of the number that use and the amount that each uses. This increases the financial and physical toll of tobacco, which increases the desire to quit, but it also increases dependency, thus making it more difficult to quit without access to resources, which, as we pointed out in the first bullet, they don't have. And this is how we get higher prevalence rates. Because when we talk to individuals in this population about their desire to quit and their willingness to do so, we see that the higher prevalence isn't about their desire or their willingness, but rather the support they are offered, and as we'll see later, whether the manner in which that support is offered empowers them or not. One final note, several years ago, BHWP had the opportunity to collect a convenient sample of over 600 individuals in substance abuse treatment facilities across Florida. We asked those individuals whether they were current tobacco users, whether they were ex or non-users, and if they were current users, whether they wanted to quit in the next 6 months or never. And here are the results that we found. About 31% of folks were ex or non-smokers. Of the smokers, 63.4% of them said they wanted to quit in the next year or in the next 6 months. Not quite as high as the national figure, but all things considered pretty close, and definitely much higher than most clinic directors or senior leadership expected we'd find. Okay, so now to return to our previous point. One area where we can make an impact is trying to reach this missing 10%, this group A, the group of about 21,000 potential new quits, if we could reach them. But let's put a pin in them and look at the 550,000 who make a quit attempt. What happens to them? Of those, most of those quit attempts will be made without any help at all. We used to say 95% of quit attempts were made with no help at all, but with the rising popularity of quit lines, the known safety and relative affordability of nicotine replacement therapy, and growing internet connectivity, more and more people are availing themselves of some assistance. So here I'm using a figure of about 60% for unaided quit attempts, which just because it's a more conservative figure than 95%. These numbers vary widely across states, and I don't have Washington's figures. Only about 7% of them are going to be successful. That's the bottom one. So this leads us to Group B, a group of about conservatively 330,000 Washingtonians each year. And of that group, about 23,000 will successfully quit on their own. If we could have persuaded all of them to use counseling and pharmacotherapy, there would be an additional 59,000 successful quit attempts in this group. So here we can see all of the various quit rate successes by method of quit. And you'll see that I used 7% to illustrate the unaided quit attempt, and I used 25% as the number of choice for medication plus counseling. And I did this to create the most conservative estimates of our back of the envelope calculation. This leads us to Group C. Group C is the collection of individuals who will seek out an evidence-based best practice, but who, without the right supports, will demonstrate success at the lower end of whatever range of category they're in. That is, someone may seek out NRT and counseling, but if they also sought our support, adding our guidance to their toolbox, instead of the 25% chance I gave them here, they may have something closer to 30. The bottom line is that the evidence base suggests that the best thing a tobacco user can do is get access to tobacco cessation counseling and combination nicotine replacement therapy or varenicline. So what are we going to do? We're going to use the 5 A's to implement and deliver the tobacco cessation recommendations of the United States Preventative Services Task Force. And if that name sounds familiar, it may be because anything with a grade of A or B from the task force must be a reimbursable service for the insurance policy to be considered compliant to the Affordable Care Act's Essential Health Benefits section. So these services are specifically telephonic counseling, group support, individual counseling, peer support, and medication-assisted treatment. And some of you you're probably already familiar with the 5 A's, at least I hope you are by this point. And some of you may have yourselves, or maybe you train people in the 2 A's and an R. Maybe you're more familiar with the 2 A's and an R, or maybe you train people in it. In other case, you're probably nervous that I'm about to start a 5 A's training, but I'm not. Many more of you may be familiar with screening, brief intervention, and referral to treatment, aka SBIRT. Because SBIRT seems to map onto the two A's and R, as I just did here, boop, boop, I want to draw the difference between the two. In short, the brief intervention component of SBIRT is more complex than the advised component of the two A's and an R. And we'll discuss referrals in a bit more depth later, but suffice to say that to make a good, effective recommendation that a person will consider following through with, you have to do a bit more of the assess and assist pieces. And whenever you make a referral for an individual to whom you will maintain an ongoing relationship, you should be aiming to close the loop a bit to make sure the client accesses those referrals and to gauge their progress with them. For example, if nicotine dependence treatment is added to a treatment plan to enhance recovery from alcohol, then the case manager responsible for checking in on the alcohol-related activities should also be following up on the client's engagement and progress in the psychoeducational or support group the client was offered for their nicotine. And we will recommend supporting those two things with a robust, carefully designed policy that begins with an analysis of the workflow. Okay, so now that we're in our second section on planning, you should be wondering if I will ever get to doing. And I will, I promise. It's worth pointing out at this time that planning well, while itself not an activity that generates revenue, reduces expenditures, or improves client health outcomes, it's nevertheless absolutely critical. So remember when I said earlier that in order to satisfy the most fundamental property of sustainability, an intervention must work? In study after study, one of the critical factors in determining whether a workflow adjustment or a new organizational policy succeeds or fails is the time spent on planning and the effort given to creating an honest, quality course of action. And crucial to the planning process itself is accountability. Who is responsible for doing what? In the realm of tobacco cessation services, supports, and policy, a crucial figure that dominates all others and of which the formation predates all other steps is the Wellness Committee. If the Wellness Committee's only function is to analyze and rework your tobacco workflow, then feel free to call it a tobacco committee or similar. We advise against creating a committee with such a narrow portfolio for a variety of reasons, but the two most important are that a committee with a narrow portfolio may quickly run out of steam while your new policy is in the doing phase. But more importantly, tobacco use impacts nearly every aspect of our clients' lives. It causes and aggravates the mental health conditions they are seeking care for. It causes and aggravates the development and progress of chronic diseases, which diminish their ability to find work, maintain housing, etc., which in turn can exacerbate chronic mental health conditions like major depression. It strains them financially, and on and on. A wellness committee serves as a central point of contact for the creation and dissemination of the new policy changes. It is the wellness committee which will serve as the main point of creativity, taking the best practices mentioned in this webinar and elsewhere and modifying them to fit the needs of your client population and your staff's willingness and capacity. For more on the Wellness Committee, like who should be on it, be sure to download our Tobacco-Free Policy Toolkit, which I think most of you have seen. I think some of you even have hard copies of it, which is awesome. It's filled with a variety of tools and worksheets to help guide your work in this area. So there is a gap between no burden and low burden. And this gap is not unimportant. So one way to get more new things into a workflow is to first analyze your current workflow and get rid of all the stupid stuff. In an effort to reduce unintended burdens for clinicians, leaders at a health system in Hawaii asked all their employees to look at their daily documentation experience and report anything in the EHR that they thought was poorly designed, unnecessary, or just plain stupid. Basically, this health system allotted a certain amount of time, 6 months, a year, I don't remember how long it was, it's in the article, for anyone to report anything that they just felt didn't matter. Now, critically, some of these things were really poorly designed, and they were able to fix those. And some of these things were unnecessary, and they were eliminated. And some things seemed unnecessary to the staff, but then the team in charge was able to explain why those steps were necessary to complete or why that information was necessary to collect. So again, going back to that number one criteria, or that number two criteria, making the tasks that the staff is performing matter, right? To communicate that they matter. And some things were holdovers. They were from previous eras, previous initiatives. They were necessary and smart once, but they weren't any longer. In all, this system estimated they were able to eradicate thousands of hours of wasted time. Now, this example here is from a hospital system with complicated and nuanced EHRs. But when I worked in a community behavioral health center, there were some small redundancies that I noticed could have been eliminated in my own paperwork. A rough estimate in that regard indicates I was duplicating information costing me roughly just 3 minutes per note. I had around 6 clients each day, and I worked 5 days a week, 200 days a year. And that's 60 hours wasted each year just for me. Multiply that by the hundreds of employees in my organization, many of which had more complicated notes than I did, and you can see the potential for pretty significant savings, time savings. And more important to me than the savings is the message that you're sending to the staff. You're saying your time is valuable. We know and understand and appreciate that. Let's put your time where it matters most, with your clients. Preceding systems changes with this kind of elimination of stupid stuff can also imply something about the new things that you're adding, that these things matter, right? It says we're the kind of people who value your time, so we wouldn't be adding anything that would take away from your ability to care. And eliminating stupid stuff is not a requirement. Only you can know if your current systems have started to suffer from service or administrative creep. But before you embark on major alterations of your workflow, you do need to know what you're currently doing so that you can find opportunities to enhance those processes with tobacco-related additions. And if you're thinking of adding services, then try to identify the processes already in place for your clients requiring complex management of chronic diseases. And perhaps if you have them, protocols for dealing with comorbid conditions. Think of it this way. Nicotine dependence is a dependence. Dependence in general is a chronic recurring condition. I'm just talking about different ways of reframing the tobacco work in terms of some other things you may already have systems for. Tobacco use is a health behavior leading to known health outcomes. Tobacco use leads to the development of known physical conditions, most of which are also chronic conditions like various cancers, heart disease, COPD. Tobacco use, like many chronic conditions, is treated with FDA-approved medicine, so aligning it with your medication-assisted treatment protocols. Tobacco use, like many substance abuse-related conditions, have established best practices given an A or B grade from the USPSTF, the task force I mentioned earlier. And tobacco use, of course, can be treated with counseling. So you probably have protocols for determining which kind of counselor or how frequently or how intense that counseling needs to be. So in those scenarios, try to figure out basic things like who does client intake? How are clients sorted and triaged? Where do they go after intake? And add tobacco services accordingly. A common workflow, for example, may be an intake process where basic information is collected, including the client's current drug regimen, brief medical history, and current complaint. Some common screening questions may be included here as well. Then the person will be sent to someone qualified to assess whether the complaint is a certain issue and how severe it is. Then the person will be sent to someone qualified to reduce the severity of the complaint with an aim of moving the client to the least restrictive environment. This may be a prescriber who can start a new prescription or alter current ones. Then the person visits an assigned case manager who will connect the client to other services, including potentially a therapist, an in-home case aide, relevant therapeutic or educational group support, etc. The case manager may also refer the client to resources outside the organization. And then, of course, finally, billing and or discharge. And that may or may not look like a common route to you. The point is not that we all should adopt a model workflow that would just work anywhere, or even that all clients within your organization would follow the same route. They almost certainly won't. The point is to refer back to those evidence-based tobacco interventions and make sure that all the people who see the client are trained to provide the service, the tobacco cessation service, that most corresponds with the services that they're already providing to that client. For example, and just to sort of reiterate some of these things, an intake person for asking questions about current drug use and recent medical history can also screen for tobacco use. A person who can perform a PHQ-9 can also do the two-question heaviness of smoking index to determine nicotine dependency levels. A certified addictions counselor the client is assigned to work with for their opioid recovery can also provide counseling on nicotine dependence recovery. A psychiatrist or psych nurse with prescribing authority who is familiar with the client's current regimen is the ideal person to recommend, explain, and monitor nicotine replacement therapy use. The complicated workflow in this slide does not imply low burden. It does not convey low burden. I can admit that. But there are 3 things I want to point out. If you were to map out any of your chronic disease clients' workflows, including substance abuse, it could be remapped to look like this. Excuse me. And the second thing I want to point out is the distribution of the work. Although tobacco cessation can require a lot of intense services or time with the client, it doesn't necessarily have to all fall on one person. Because when it all falls on one person, it can be experienced as a really high burden task. But if we distribute those tasks across the workflow, it's what would be high burden for one becomes low burden for many. And finally, the third thing I want to point out is that not everyone gets every service. While the intensity does go up for each remaining client through a tree diagram like this one, we can direct clients out of this workflow as they each reach their appropriate intensity level. The slide here is only one way to conceptualize this. I'll introduce another way in the next section. As I already mentioned, this is not a 5 A's training, but I do want to return to this concept as it is the critical way to tailor our services in such a way as to ensure that everyone gets as much support as they need and no one gets too much. That is, I want the 5 A's adopted to ensure healthcare equity and not healthcare equality. One way to make sure that an intervention is sustainable is to make sure it works. So we want to provide the maximum support required to motivate a quit attempt and to maintain that quit attempt. The second thing we need to do is not provide any more care than is necessary. Additional time spent with a client that doesn't need it, additional pharmacotherapy provided to a client that doesn't need them. These are resources that once they're spent, they cannot be spent on other clients who do need them. Also, ramping up intensity on a client that doesn't require it may actually create resistance in a client that was initially willing to accept assistance. So ask is our screener. Simply put, we just want to know if the person is a tobacco user, and if not, they don't need any additional tobacco-related services. And this could be anywhere between 20 and 55% or more of your entire client base who don't need any further intervention after this initial screening question. However, we do want to screen them each at each and every visit. And I know, well, this is true for everyone. It's especially true for young people below 18 and for anyone newly exposed to high levels of smokers, like those recently assigned to residential treatment or jail or prison. And I'll add that highly agitated or unconscious individuals obviously don't need to be screened immediately. I'm often asked if every client at every visit is realistic when clients are coming in maybe multiple times per week. And I have two answers to that. One is probably. It literally only takes a second to ask and record an answer. But the other one is, I don't know. Only you really know your workflow and your staff capacity. I would set some parameter to measure against. Once every 12 or 24 months are two common standardized measures. I'd prefer more frequently since folks can change their minds overnight. Moreover, it's not just about obtaining a smoking status. Ideally, you'd want to make sure you catch anybody who suddenly changes the level they smoke. Changing levels can be an early warning sign of an acute onset for several conditions of concern, including major depression and suicidality. It can also be indicative of major life changes like the loss of food stamps or other nutritional support or loss of sleep. And lastly, we should also keep in mind that as a person's consumption of smoke changes, the potency of other medications may be changing as well. That is, as smoke consumption goes down, other medications become stronger. So frequent check-ins to check for tobacco use levels has a solid grounding in the provision of medicated related services. So next, we want to advise all tobacco using clients that quitting tobacco use is the best thing they can do for their health. This message should be delivered in a non-judgmental way and also connected to something that makes the advice immediately relevant to the client. Tobacco use's connection to the actual impetus of the visit, for example, or in this case, or in a lot of your cases, that quitting tobacco can help sustain recovery from other substances. From a workflow efficiency standpoint, you'll have to make the calculation of how far up the advice comes. The higher up the advice comes from, the more expensive each minute becomes. On the other hand, from an effectiveness and efficiency standpoint, an intake staffer advising someone to quit doesn't really impact their cessation rate very much. However, when that advice comes from a physician, it more than doubles the chances of abstinence after 5 months. In the next stage, we want to assess the client on two fronts. First, we want to assess the client's willingness to talk with us. If they're pre-contemplative about their nicotine use, that is, if they're among the set of individuals who have no intention of quitting ever, then we don't force any further engagement. And this could be anywhere between 20 and 30% of all current tobacco users in your system. For contemplators, we really want to simply provide them with some educational resources. And if they're willing, and we have the time, some information regarding the dangers of tobacco use that they may want to consider. Or if they have questions about how to quit, tools they can use. We can provide those as well. I will address the second half of assess and assist together. This is really our counseling component. And how much time you spend with a client will be determined by their need to some extent and your capacity to satisfy that level of need. And firstly, I want to say that if you are thinking of providing cessation services yourself or in your system, the assess and assist stage will satisfy the condition that most insurance payers, including Medicaid, have for a reimbursable tobacco cessation counseling session, if it is provided by a qualified provider. That is, don't confuse counseling in this context with therapy. This stuff doesn't have to come from a therapist per se. To satisfy counseling, a qualified provider should discuss the harms of tobacco use in ways relevant to the client and the benefits they can expect from quitting, those two things. Counseling also should include an exploration of the client's triggers, their history with quitting, and identifying some potential barriers. In addition to allowing us to check the counseling box, this information allows us to create a quit plan tailored to that person's unique needs. Finally, some accrediting organizations want the advice or counseling piece to also include a pharmacotherapy recommendation. Joint Commission, for example, requires a pharmacotherapy recommendation. However, if you have opted to not provide any services yourself at all, and instead plan to refer your clients elsewhere for direct interventions, you may still consider assessing the stage of change and their level of dependency, because these will help significantly in making sure that what you're recommending is the right intervention for the right intensity. And I won't go into too much detail on the topic of assessing dependency, but I strongly recommend using a validated instrument and using the same one organization-wide. And if possible, adding it to your EHR if that's a thing, or your electronic records, whatever those may be. The U.S. Preventative Services Task Force recommends the ASSIST tool to satisfy that particular requirement. I normally recommend either the Fagerstrom test for nicotine dependence or the heaviness of smoking index. If there are questions about that, I can answer those in the Q&A. So just to recap how performing Ask Advise, stage of change assessment, and dependency might impact your workflow, I used here the results of the survey shared earlier in the presentation, the one using results from the residential substance abuse facilities in Florida. And here we see that we're asking everyone who comes in if they are a tobacco user. Approximately 69% say yes, and then they are advised to quit, and also asked how ready and willing they are to quit. About 44% say they want to quit in the immediate future, and this is actually a slight exaggeration. Normally, we would divide readiness to quit between those who plan to quit in the next 6 months and call them contemplators, within the next 3 months and say they're planners, and those who want to quit within the next month are in the action stage. For purposes of illustrating how low your burden gets as it goes forward, I included all those who say they want to quit within the next 6 months as graduating to dependency assessment. And then dependency, you'll find that your dependency answers can be tiered if you're using like the HSI or the Fagerstrom that I just mentioned, the heaviness of smoking index. And they're tiered into 3 groups, high, medium, and low. And we don't have exact figures from the survey that we did, but they would fall into something like this with, given your particular environment within substance abuse or in community behavioral health, you're going to see a lot of folks who are in that higher range. That's going to be the bulk of that 44%, and then it's going to sort of go down from there. So finally, in this section, I want to talk about referrals. Clients prefer as many services and products as possible to be available in the same transaction space. And this is why department stores like Walmart and Target have added groceries. This is why Amazon is our most popular retailer. Similarly, it is one reason among many that integration is a quote unquote integration is a driving force in our healthcare delivery sector. The more important reason is that there is no hard line between mental and physical health. Some mental health issues cause physical health problems, and vice versa. Some co-occur because they share a similar root cause. So making sure that mental and medical care is provided at the same time by a team of individuals in continuous communication is essential in the treatment of a dependence as strong as nicotine causes. Which is to say that all things being equal, the more the services described above that you can provide yourself, the better off your clients are. Failing that, you want to find a source for each of the services that you don't provide. And ideally, you want to have a systematic link between you and those who you refer to, those who refer to you and those that you refer to. If, for example, you routinely send clients to a nearby university setting for tobacco cessation group psychoed, you'd want to formalize a means of getting information about the client's progress in the group back to their providers at your or their care team at your organization. Similarly, if you regularly get referrals from a nearby jail or a halfway house or something similar, Formalizing the transfer of paperwork could mean that if they are screening for tobacco use or assessing willingness to quit, then you can remove those tasks from your workflow. So, two critical things about referrals: they have to be relevant and useful to the client. A client who has informed you they're not available on Wednesdays should not be referred to a group that only meets on Wednesdays. This doesn't get a check mark in the provided a referral box. Similarly, a referral to the quit line does not constitute a relevant referral if the client has insisted they don't want to use the quit line. And referrals need to be made enthusiastically. We know, as well as we know anything, that seeking any help for tobacco cessation can at least double the chances of success for any given quit attempt. So at a minimum, the quit line, the group, a counseling session, a round of nicotine replacement therapy, all of these things are better than nothing at all. And sowing doubt undermines that success even before it begins. The final 3 points on this slide all go toward developing a robust partnership with your referral sources and those that refer to you. The more knowledgeable you are about the locations, times, personnel, and unique characteristics of your referrals, the more appropriate you can be assured that they are, and therefore the more enthusiastic your recommendation can be, and the better you can be about setting proper expectations with the client about their future experience, which lowers the bar for them to take that risk. So I do want to go back a little bit and talk about that second point. And I want to illustrate, I'm going to illustrate how important it is with just a couple of examples. A few years ago, BHWP partnered with National Jewish Health, who has several state contracts to run quit lines. And callers in those were divided into two buckets: those who reported no mental health issues and those who reported having at least one mental health condition. Those who reported a mental health issue were further divided into two buckets: those who thought their condition would affect their outcomes negatively, and those who did not think that would be the case. Now, in aggregate, those in the mental health bucket had lower abstinence rates at 6 months than those in the no mental health bucket. However, once we look at those who thought their conditions would hurt their abstinence and those who did not think that, something really interesting pops up, or interesting to me at least. Basically, those who thought their mental health condition would not impact their chances had much higher abstinence rates than those who thought it would impact their cessation. So, which is to say that your state of mind and how you feel about your quit attempt and the confidence that you have that you can do it with the supports you have really, really does matter, and it shows up in quite significant ways. We also see this show up in other areas as well. Every placebo pharmacotherapy, patch, gum, lozenge, nasal spray, inhaler, bupropion, varenicline, all the placebos perform worse than the real drug, but they all also perform significantly better than if nothing had been provided at all. So there still is an active placebo effect with those medications. And back in the 1980s, psychoanalysis was a pretty common modality for those seeking cessation. However, it became really evident that the psychoanalyst exercised a lot of power of suggestion over their clients. If the psychoanalyst believed that the client, due to life stress, for example, would be unable to quit, then that client was unable to quit. Essentially, in this world, it's worth keeping in mind that nicotine is an extremely addictive drug. It is legal. It is normalized. It's a normalized activity, if not in our clients' worlds, sometimes a moral one. And it's still fully ingrained in our culture with movie characters smoking, billboards, magazine ads, etc. So lapse and relapse are common. Your referral sources, no matter how good they are they're most likely, they're going to have more failures than successes on their scorecards. But in nearly every case, some intervention and support is better than nothing at all. So make that referral enthusiastically, because optimism is empowering. And so finally, we need to talk about a range. A range is simply making sure we follow up with our clients at regular intervals going forward. We want to make sure we're checking in on them about questions and concerns they may have. We want to confirm they are taking any pharmacotherapies that we've referred them to or recommended for them or prescribed for them. And we want to make sure that they're taking them in the right way. Okay, so I could spend another hour simply just talking about how to look at and set benchmarks, how to engage in unintrusive formative evaluations, and how to move data into meaningful action. And unfortunately, I don't have time for that. But I do want to offer a few tips in that direction. Like planning, Evaluation does not directly lead to a financial return on investment. However, by improving process scores and potentially outcome measures, because theoretically those are linked, it helps us simultaneously enforce the organizational commitment to these services, and it adds to an organizational culture that values wellness, learning, and improvement. So, where do you get your benchmarks from? This can seem fairly daunting. If you have access to making your own medical record queries, whether that's EHR, electronic notes, whatever, you can start there. The best source for areas of improvement is what you've been able to accomplish in the past. This list assumes that that's not the case. Instead, refer to national, state, and county level data. National surveillance systems like the Behavioral Risk Factor Surveillance System can tell you what your state and sometimes your county level prevalence rates are. You can then estimate or run a report to figure out if your particular catchment area is exhibiting a greater need for service than that, and it most likely is. You may also be able to figure out your state quit rates and the success rates for all of the various interventions. Some states handle that sort of surveillance on their own. I know that Colorado does. For example, if you know that statewide, the Washington state quit line has a success rate of say X percent, say 25%, are those that you're referring quitting at the same rate? Lower, higher? And is there something that you can do to improve that cessation figure for the quit line, or for the people you refer to the quit line? Set both short and long-term goals. For example, if you know that you are currently advising 75% of the clients you screen, you may be able to make small changes early to move that figure to 85% in the first year, and then 90% by the end of year 2. A long-term goal and a reach goal are different. A reach goal may be something like, we will work very hard to get 90% of our staff trained in how to run groups, but the reality is that most likely you're going to get something like 80%. A reach goal should still be achievable, but they're used for inspiration and planning at the beginning rather than for critical review at the end. Finally, be honest with your benchmarks and why you did or didn't hit them. As long as you moved in the right direction, or if you're confident you know why you did not, it's a success. When I was a social worker, each year the staff would gather to hear a bunch of organization-wide statistics. And some of these, when relevant, could be broken down into clinics and teams. And they would say things like, this year, 60% of new intakes were diagnosed with a depressive disorder, primary or secondary. And this would go on for hours. And the whole time I would be sitting there, I was just thinking, just getting angrier and angrier. Like, what does this mean? Is that more or less than the year before? Is it higher at my clinic than the other ones? Should we change what we're doing because of this? Do we need more training in depression? Or are we over capacity? The point of collecting data is not just so that we have it and can have your hours-long annual team meetings. We need to know, like, compared to what? What are we doing with this information? We can do things in the short term, like comparing them across clinics, across providers, between cities. And here again, not just for the fun of it, but in order to decipher meaning from the data and to determine actions from the meaning that we find. We're gonna get this wrong, right? And probably a lot, but that's okay. As long as our process is thorough and honest, we'll likely to continue to make progress over time, even if we miss the mark a bit when we're trying to pinpoint causality. But some important issues to consider here are, is this number higher or lower than previous years? Is the improvement or decline attributable to our choices or shifts outside of our organization? Are successes replicable? And when numbers are low, if trends are going the wrong way, is that a fixable issue? Can it be solved through systemic fixes like additional trainings? Or is this a personnel problem? As you're thinking of new processes, there are two tendencies that should both be avoided. One is to collect no data at all, just to assume that because the intent of the changes you're making are well-meaning, that the end result will be good enough, even if they're below expectations. The other is to collect a lot of data simply because once you're in the process of collecting some new things, you may as well collect everything. If you combine this slide's advice and the last one, it implies an important piece of advice by itself. Determine in advance how you will know a program has been successful. Then collect whatever data you can that will quantify that success. Ask yourself, if on this date a year from now, this number that I'm thinking about collecting is X, this number becomes X in a year, what will that tell me? What directions will that give me? And if you don't know the answer to how you would change your program based off that particular number, then you might reconsider whether you should be collecting it at all. So some of this seemed really hypothetical, really conceptual maybe, but we did talk about a lot of things that you can literally just do or start doing or plan to do. And this is what that to-do list looks like. And I'm not going to go through them all again because that's literally the presentation I just went through. So I would need another 44 minutes and 35 seconds to do it. But it is available on the slide deck, which will be available to you on the resource site later today or tomorrow. At any rate, eagle-eyed observers will note that the headline, the section titles for this presentation were Planning, Planning, Doing, and Study and Act. This webinar was structured around the Deming cycle, also known as PDSA, Plan, Do, Study, Act, and sometimes PDCA, Plan, Do, Check, Act. This is a user-friendly program improvement process with a long history of success in the healthcare delivery field. You don't have to choose this one to govern your policies, but I do recommend that you choose some process that's sort of embedded in your planning process for how you're going to evaluate and surveil your program and make improvements on it. If you are interested in using a rapid improvement process like PDSA, which is pictured there again on the left, you can also just use download from our website that form on the right. We call it the Dimensions Action Plan. It asks you to identify 2 short-term goals and identify some of the barriers to achieving that goal. And then some of you may have even heard me say this before, but look at those barriers and determine if they need a strategy themselves to overcome, they become one of your goals at that point. For a brief summary of evidence-based best practices, I already mentioned the tobacco-free policy toolkit, but we have a bunch of other free toolkits on our website. I show here tobacco-free toolkit for healthcare providers. The advice in there, it says healthcare providers, but it really is across care engagement sites. That really weird, complicated workflow slide comes from this resource, also available on our website for free. Again, it says for healthcare clinics, but in truth, most of the advice in there can be translated pretty easily into other care sites. And there's that again. And then, of course, lastly, we always mention the National Behavioral Health Network for Tobacco and Cancer Control. They're always putting together new resources and new materials and hosting webinars and all kinds of stuff. So definitely check in with them. And I think that's going to do it for me. So at this point, we can open it up for questions. And just as a reminder, you can chat those in, or you can use the Q&A box, or if you raise your hand, I will unmute your line and you can ask your question directly. Thanks everyone for listening to me today. Okay, well, not seeing any questions coming in, not seeing any hands being raised, I will go ahead and in the meeting. Remember that I do want to say that I appreciate you guys showing up today and listening to today's presentation. If you do have questions and you don't want to ask them right now for some reason, if you just want to collect your thoughts, you are welcome to call or email us anytime. And of course, you can always reach out to Nick Fradkin or George Banks as well for additional questions. They can get your questions to us in that way. All right, well then I'll give you guys back, like 12 minutes of your hour. Thank you all again.